Welcome everybody to the Health Innovation YGK Ecosystem Partners and Kingston Health Sciences Centre Decision Maker session. And this is something that I think we hope to repeat periodically. The purpose of the session is to bring together partners from the Health Innovation YGK, so we'll just call it the HI YGK innovation ecosystem, as well as executives, innovation and procurement leaders from Kingston Health Sciences Centre, the Kingston Health Sciences Centre Research Institute, and Queen's University Faculty of Health Sciences to explore identified innovation priorities and to provide education about how to procure or pilot innovations in a hospital setting. And so the main objectives of the session are going to be socializing Kingston Health Science Centre's innovation priorities, identifying additional complementary community resources, and discussing other organizations that could be included to help with these identified innovation priority areas. Second is to clarify how to procure or pilot into a hospital setting to help innovators and entrepreneurs focus their thinking about what it takes to bring innovations into a hospital. And then the third priority is going to be identify how to identify and funnel hospital-based problem statements into the local ecosystem of healthcare innovation companies and entrepreneurs, schools, and other potential partners that we have here. Okay, I'm Jim Mccauley, and I'm the academic director of the Dunin-Deshpande Queen's Innovation Centre, and I'm also a professor at Queen's as well. And I'm going to be your facilitator for today. And so what I'd like to do is just remind you of a couple of things. First of all, we are recording this event so that people can look at it later. A transcript will be available throughout the webinar if you want to read what's being said. What we'd like you to do is when it comes time to have the discussion and question and answer session, to please use the raise hand feature or type your question into the chat. And so my colleagues Bruna and Megan are going to be monitoring the chat and will be helping to curate the questions that we get. What you're going to find is we're going to go through 4 different parts of the main presentation, and we'll pause at the end of each one to see if there's any immediate or pressing questions. And then what we'll do is we'll save the questions for the discussion at the end, and we've set aside 30 minutes for a question and answer session. Okay, so it's my great pleasure to introduce Dr. David Pichora, the President and Chief Executive Officer of Kingston Health Sciences Centre. Dr. Pichora serves as President and CEO of Kingston Health Sciences, an academic tertiary care centre that serves a population of 500,000 people from across southeastern Ontario. In 2017, it was formed by bringing together the Hotel Dieu Hospital and Kingston General Hospital to form KHSC. Dr. Pichora was chosen as its inaugural president and CEO. He's an orthopedic surgeon, a professor of surgery and of mechanical and materials engineering at Queen's, and he served on the medical staff at Hotel Dieu and Kingston General Hospital since 1986. Before accepting the role as president and CEO of KHSC, he held the position of CEO of Hotel Dieu Hospital, and prior to that, its chief of staff. He also served as divisional chair of orthopedic surgery at Queen's and Hotel Dieu and Kingston General Hospital. So Dr. Pichora, please, looking forward to your talk.
Thanks very much, Jim, and welcome everybody. Good afternoon. It's great to have everybody join us today. I'm going to try to give a fairly quick overview if I can, because I think we want this to be an interactive back and forth discussion. But I'll try to orient you to some of our opportunities and realities in the tertiary healthcare sector. Obviously, innovation is the focus of today's discussion and how that can fit into our strategy and the opportunities that might present themselves from day to day. I'm going to spend a bit of time talking about our current priorities and opportunities and a little bit about the bigger system context. Generally, how healthcare's quadruple aim guides most organizations, how hospitals have become rapidly integrated into the healthcare system over the last few years, but especially since the onset of the pandemic, and then a little bit about how we're moving more and more towards a value-based healthcare system. So Carrie, next slide, please. So at KHSC, we have four main strategic priorities or strategic directions. They're very broad-based, and you'll notice some similarity with the quadruple aim, which I'm going to mention in a couple of minutes. So the first one is around quality in every patient experience, and this would spread out to patient and family experience. And how can we innovate and improve ways to ensure that we're providing quality care? And again, during the pandemic, we've changed an awful lot of things that we do, and hopefully those learnings will continue and grow in the future. The second one is about nurturing workplace wellness and supporting our staff. So nurturing our passion for caring, leading, and learning. And everybody's familiar with the staffing shortages in every type of industry throughout the world right now. It's a major issue for us today. So how can we take best advantage of the scope and scale of the people we have working for us? At KHSC, we have about 6,000 employees, about 1,000 medical staff, an untold number of learners, probably a couple of thousand, and volunteers as well. The third item is around public health, and this has become a bigger and bigger mandate for hospitals. How can we improve the health and safety of our community through partnerships and innovation? This is really a key one for you to think about today, because a partnership issue is a key and fundamental aspect of what we've been doing in the last few years. And so hospitals really have become very engaged through the pandemic, especially about community and regional health and safety. And the fourth is launching KHSC as a leading center for research and education. We're ranked as one of the top 40 research hospitals in the country and had the second highest increase in research spend in the last couple of years. And if you think about our values, because we like to think of ourselves as a mission-driven, values-based organization, it's compassion, respect, partnership again, excellence again, and innovation. So those really resonate with a discussion on innovation and how to improve healthcare in the future. Next slide, please, Carrie. So here's just a few of our current priorities, including but not exclusive to the pandemic. Right now we're working really hard to maintain, expand, and restore our regular clinical operations, to get back our full slate of surgeries and other procedures. And today, the pandemic is a challenge, but really the staffing shortage is our biggest challenge every day in this regard. So we're looking for ways to stretch our staff and offer care in ways that enable us to do that, including virtual care, which we've done a lot of in the last year. The pandemic response and eventual recovery has changed things that we do. We've introduced, for example, all sorts of digital and virtual platforms for protecting the organization, providing care. Cybersecurity has become an enormous topic for healthcare in the last year or so. We're dealing with hospital accreditation, so we have to measure up to very strict standards, and our next accreditation cycle occurs in April. Some of you will have heard about our redevelopment project, a massive project for KGH to replace 5 end-of-life buildings with a new tower. It'll have more patient care floors, helipad on the roof, and replace some of our most important facilities, ORs, labor and delivery, neonatal ICU, the emergency department, our labs, pharmacy, and other key elements of the hospital. In fact, amongst the most expensive things that we do. Another big project is our regional health information system. So this is about replacing our electronic medical record or patient care system, but not just the one we have at KHSC, which is end of life, but for every hospital in the Southeast. So 6 hospitals, we're going into this together, and so that we'll have one patient, one record, one healthcare system. And this will be the digital platform for care in the future, and it will support work in our Ontario health team to bring in integrated care and hopefully bring primary care and other healthcare providers in the region into one integrated care supported by a digital platform in the background. And then finally, we're working on partnering with government to find innovative ways to support new technology and innovative procedures. For example, our Da Vinci robot program. You know, it's being widely used throughout the country now, but the funding system that Canadian provinces don't really support this type of innovation because it's a big front end cost and we're not allowed to run deficits to support innovation. And so we're trying to work with government to provide ways of sustainable growth strategies for innovative, minimally invasive procedures like robotics in this case. Next slide, please. And then finally, I mentioned the healthcare's quadruple aim earlier. And again, this would be the backbone of the strategy and thinking for most healthcare organizations throughout North America and increasingly around the world. Again, there's some synergy with our strategic plan. So enhancing the quality, safety, and patient family experience is one key element. How do we look after the patient in front of us? The second one is improving population health. And again, what can we do to improve the health of our general population, support our partners out in the system, whether that's primary care or public health, to improve the health and safety of our population. Again, workplace well-being is critical because we can't support care without supporting our staff. So improving provider well-being. And then finally, this is where the value equation comes in, enhancing capacity, efficiency, and value for money. And value-based healthcare is about creating quality outcomes that matter to patients divided by the cost of providing that care. So it's about affordability and efficiency. Our budget at KHSC is very, very large. It's the biggest budget for any provider in our region, but we have to stretch that over a huge range of very complex procedures. Next slide, please. So that's a very quick overview. Hopefully it's a bit of a taster to get discussion going. And Jim, maybe I'll stop there to see if there's any questions.
Thank you. Thank you, Dr. Pichora. So any quick clarification questions for Dr. Pichora before we continue? And just a reminder, we will have an opportunity to have more questions and more discussion at the end, but we just wanted to pause for a minute. Okay, then what I'd like to do now is move to the next presentation and introduce Dr. Elizabeth Eisenhower, who is the Kingston Health Sciences Centre Innovation Lead. She's a Canadian oncologist who spent a large part of her career undertaking phase 1 and phase 2 trials of novel cancer therapies through her role as director of the Investigational New Drug Program in the Canadian Cancer Trials Group. She's an emerita professor in the Department of Oncology at Queen's and was department head from 2012 to 2017. In 2018, she became the innovation lead at Kingston Health Sciences, and she's an officer of the Order of Canada, received in 2017. And in 2021, she received the Canada Gardner-Whiteman Award in recognition of her contributions to cancer research and leadership internationally. Dr. Eisenhower, please.
So thank you very much. I believe I am sharing my slides. Someone should tell me if I'm not.
No, you're good.
Good. I'm really pleased to speak with you this afternoon about innovation priorities at Kingston Health Sciences Centre. What we're going to be discussing in the next 15 minutes is a little brief overview about what we mean by health innovation at a tertiary hospital, how we went about developing the major themes that we have now in the KHSC innovation portfolio, and giving you some quick snapshots on progress against 3 of those themes so far. So this is a construct that is not unique to me. Others have used this to describe health innovation, but basically it's comprised of 3 essential interlocking elements rather. Health innovations, by definition, have to be something new, but they also have to have associated with them evidence of benefit and the ability to be adopted within the health setting. And to expand on these a bit, Something new could be one or more of a process of care delivery, the people and the types of healthcare workers we deploy in a new situation, interventions, including drugs, but also other types of interventions, surgical interventions, for example, technologies and techniques. The evidence of benefit means one or more of patient outcomes, patient experience, provider experience, or capacity and efficiency have demonstrably improved benefit when the innovation is deployed. And as you might imagine, having heard David speak a minute ago, these map fairly closely to the quadruple aim descriptors. And by ability to be adopted, I mean there has to be funding such that something is affordable to adopt. It has to be scalable and usable by the personnel that we have within the system. So those three elements are what together comprise healthcare innovations. At Kingston Health Sciences Centre in 2018, they decided to call out innovation in a new way by creating an innovation lead position, which I assumed. And the primary purpose of the role in the description given to me at that time was to lead the design of an innovation portfolio at Kingston Health Sciences Centre to encourage, nurture, and celebrate innovation by staff at all levels of the organization. And these words encompass the intent to create a culture of innovation at the hospital, even moving beyond the elements that might be found within a specific portfolio theme. So what I and others did was to begin by defining the goals for our innovation portfolio, which mapped very closely, of course, to the description I just gave you of the quadruple aim. I held 53 different meetings and interviews with leaders, committees, departments, not just locally, but also regionally, provincially, and even some international folks, to learn and listen about what others felt were key elements of a tertiary hospital innovation portfolio. All of this led to the creation of what I called a discussion document in the fall of 2018, which recommended several themes that might be within our innovation portfolio in both an internal and external pillar. By internal, I meant here at Kingston Health Sciences and Queen's Faculty of Health Sciences, and external comprised the region in which we worked. It also described the process and criteria for priority setting and provided clarity around a topic that garnered a huge amount of discussion in the initial days of this work. And that was tried to provide some clarity around what is research versus innovation, what's quality improvement versus innovation. And because that was such a hot topic, I thought I would show you a couple of slides outlining how we decided to resolve it. So between health research and healthcare innovation, there isn't a sharp line of division. Health research, of course, comprises basic discovery, the development of novel interventions, clinical trials, and then movement into early translation, the development of new technologies and evidence generation, which then are spread, adapted, taken up, and partnerships and models of care delivery are formed. And all of these represent sort of a continuum between discovery and implementation, which I think encapsulates how we see the difference between the research side and the innovation side. So that discovery to implementation continuum. Quality improvement also involves implementing innovation as innovations in care. And it was important to distinguish between the nature of things that might be within an innovation portfolio versus a quality improvement portfolio. And this slide captures how we saw the more transformative early translation of new technologies, the spread, uptake, adaptation, into the process improvements for quality outcome, safety, and efficiency at the other end, again describing a continuum between the more transformative changes that might be innovation type descriptors versus incremental improvements that might fall into a quality improvement portfolio at the hospital. Now, I've often been asked, why do you have to define themes in an innovation portfolio? Isn't anything good to go? But the reason to call out specific thematic areas were several. First of all, given that we can't always do everything, we can identify through creating a portfolio of specific themes, areas where there's major need and interest, where our efforts can be placed, and where investment could be directed should we ever be so lucky as to get it. And I'll come back to that. But I do want to highlight an important caveat. Just by calling out several themes for the innovation portfolio, we never intended to restrict innovation to only these areas. And that's an important thing for attendees at this workshop to retain. How we identified the themes, we looked at two things. We wanted to build on where we were already strong in research. In other words, areas where that research to innovation, transformation, or implementation might take place, but also on the population and hospital needs. We also felt it critical to align the Kingston Health Sciences strategy with priorities in research and innovation within Queen's Faculty of Health Sciences, because the clinical leaders at Kingston Health Sciences are, in fact, the clinical leaders within Queen's Faculty of Health Sciences. Out of all this work, 5 internal pillar themes emerged, as shown here: digital health, AI, and machine learning; 21st century interventional medicine, such as that of the Da Vinci robot or interventional radiology that Dr. Pichora described; what we called new frontiers in integrated care, where we were looking at innovations within our region, outside the hospital, between specialists in primary care and other providers, with a specific sub-goal of elimination of wait times for access to care; novel business models in procurement; and next generation tertiary care in lab imaging and the health information system. Out of these 5 themes, it's important to note that some of these represent actually what we would do to patients to improve their outcomes, how we would do it, that is, the models of care we would deploy, and how we would support it through novel business and procurement models. 3 of those themes, as shown here, were selected as the initial focus for the innovation team. And I should say, at this point, the innovation team was still, I think, 1 day a week of me. So we had a lot of fun making things start to happen. And what we decided to do was to begin with workshops, bringing together people, experts, and most importantly, evidence that might lay out a work plan for development of these themes further. And we were fortunate to scooch in the first workshop on digital health, machine learning, and AI in February 2020. And that workshop report's actually available on our website in the innovation section, where we identified opportunities for where we might want to go and grow. And there's ongoing work and discussions in this area around digital care, data analytics, collaboration with the Center for Health Innovation, a new center that Amber Simpson from the Department of Computing is leading, and a webinar series. The second theme, the 21st century interventional medicine, minimally invasive approaches, we actually designed a really fabulous workshop to be held in March 2020, which unfortunately was canceled because of COVID. So this work was paused within the portfolio, but there continues to be within the hospital a lot of things going on in this space with robotic surgery, interventional radiology, and more. The third theme, new frontiers in integrated care, and specifically timely access to specialists, was also a workshop where we put together a lot of evidence-based innovations that we might consider adopting. But this workshop was also canceled because of COVID. Nonetheless, because we could already see we were in deep trouble with the impact of the pandemic on care access, we decided to proceed anyway to begin some work on this particular theme. And I'm going to spend the last few minutes really describing some of the things we've done during the pandemic on this one theme in our initiative. I suppose, at least for people that are local, I don't need to show you a slide like this, that is a result of a survey of specialists at Kingston Health Sciences in August 2020, where we determined that, that many specialties had more than 500 patients on a wait list who don't have an appointment booked. And many specialists were booking out more than 12 months into the future to see non-urgent referrals. And we knew that the COVID-19 will only make this worse, as we had to restrict or scale back some of our services and clinics to cope with the brave new world of the pandemic. So looking at why this was so, why we had such a problem, and I have to say, this is not unique to Queens and Kingston. It is everywhere across the country in some areas, long waits for non-urgent consultation. And it was quite clear that it was could simply be described as this imbalance between our capacity in terms of physician and allied health numbers and clinics for in-person visits to match the volume of referrals, the need and the demand for referrals that were coming our way. So we looked at the evidence and identified a number of different innovations that could, on the one hand, enhance capacity, and on the other hand, reduce or rebalance the referral volumes, and decided to set up a series of working groups exploring what it would take to implement these here. And in the summer of 2020, when this work began, we put out a call for interest, and we gathered together 71 volunteers, 41 specialists, 15 primary care physicians from our region, 7 patients, and 8 administrative and academic leaders into those 5 working groups, overseen by a leadership team and supported by an evaluation group that was going to help us figure out whether we were having the impact we wanted. And I'm just going to highlight 3 of the working groups' outputs, and some of these overlap, as you will see, with the other priority themes. So the first working group was looking at central intake of referrals using digital tools. Most referrals are still sent by fax from primary care or from the emergency department or from colleagues in other hospitals. And we knew from evidence such as that shown in the diagram on the right, that when you move to a central referral model where patients are referred to a group, not individual physicians, all of whom could see that patient, and assign the next available appointment based on urgency, it reduces wait times overall, but also enhances equity of access to care. So what we did was we developed our criteria for an ideal central intake system with a plan to make this go digital. So electronic referrals and an electronic waitlist management system. And thankfully, with Ministry of Health funding, we obtained a few months ago, using an e-referral or Ocean tool and an e-request waitlist management system from Novari, we are in the midst of setting up pilots to completely convert 4 specialties to this digital referral central intake mechanism. This will go live in March 2022, and we want to spread it to other specialties, not just locally, but regionally. And to do that, we are hoping to get further support for this work. The second working group examined an approach that would ideally reduce some of the routine referrals that wait a long time by providing primary care physicians with tools and guidance to manage those patients with support from specialists by phone or e-consult without the need for a referral. And we knew from the work done in Calgary by Mark Swain in the gastroenterology group there, that through this type of work, they reduced a wait list of more than 2,000 patients with various gastrointestinal problems down to almost 0 within a year. So we had good evidence that this approach was useful. And together with primary care physicians in our region, we worked together to develop a number of pathways, 9 so far. 3 are being launched in continuing professional development events this year, and 6 are scheduled for spring of 2022. And the evaluation is really early, but the data so far seems to show that there's a reduction in the number of referrals as family physicians are being directed to use these pathways instead of putting patients on a 2 or 3 year wait list. And the third working group was an effort to expand capacity by moving some of our specialists into clinics within a primary care setting. It has often been said that one of the constraints we have in seeing more patients is, yes, having adequate numbers of highly qualified personnel and clinicians, but also clinic space in which to see them. So we knew from psychiatry's experience here that having a specialist embedded within primary care offices can reduce wait lists, and it also increases education between primary care learners and specialists and builds relationship with shared care models. So we surveyed primary care to find out what specialists or specialty clinics might be of greatest interest and whether they would be interested in hosting one. And we've piloted now over the last 6 months 3 new specialty clinics launched in the spring of 2021, general internal medicine, general pediatrics, and gynecology. And we just had an evaluation and workshop last week to review the patient, primary care, and specialist feedback, all of which was positive. So the next stage of this will be to see when and if and how and where this can be expanded further. So to just summarize, I guess it's self-evident to all of those in this meeting that innovation in healthcare really is vital to achieve improved outcomes, improved patient and provider experience, and enhance efficiency. And I haven't talked about the kind of innovations such as drug development or those sorts of things, which I spent 30 years of my life doing, because within the hospital setting, innovation tends to fall more into the procedures, the processes, and the types of work we do within the hospital. The innovation portfolio developed with Queen's Faculty of Health Science input has identified major themes, which I've described, around which we are currently clustering our time, effort, and desperately seeking investment. We do have a lot to do. Important for you to understand, hospitals really don't have a budget line for innovation, nor do they have a mandate to support innovation work. This comes from the need to make things better that all of us feel so desperately. So a lot of this comes off the side of the desk of very busy people. We're just beginning our work on these 3 priority themes, and I direct you to the website where you can find more information on these themes and the workshop report that I referred to earlier. And with that, I thank you for your attention.
Thank you, Dr. Eisenhower. So just pausing quickly again, are there any clarification questions that anybody has? Okay, I noticed that there was a question about timelines. I think that's a question that we can save, I think, for the question and answer session at the end. So what I'd like to do now is to introduce Dr. Michael Fitzpatrick. He's the Chief of Staff and Executive Vice President, Medical and Academic Affairs at KHSC. He's the Executive VP of Medical Affairs, and his responsibilities include oversight of ambulatory care, pharmacy, and the innovation portfolio, working with the innovation lead, Dr. Eisenhower. The inclusion of ambulatory services with innovation in the portfolio is synergistic, with the aim of harnessing innovative approaches to enhance access to ambulatory care for patients in southeastern Ontario. Dr. Fitzpatrick is a professor of medicine and respirology and of biomedical and molecular sciences at Queen's. And prior to his current role, he served as Chief of Staff and Vice President of Medical Affairs at Dieu Hospital. And he's a former chair of the Division of Respirology and Sleep Medicine in the Department of Medicine at Queen's University, Dieu, and Kingston General Hospitals. So Dr. Fitzpatrick, please.
Thanks very much, Jim. Well, let me just start by saying that putting my brief talk in perspective, David Pichora has given a very nice overview of the main themes in healthcare and how that transformation in healthcare is occurring towards a value-based healthcare system, and shown us the various strategic aims of our organization. And then Elizabeth put a lot of thought and effort into determining what the main themes of innovation in healthcare are for the future. She sought the advice of experts locally, provincially, nationally, and internationally before coming up with those major pillars of the innovative strategy. What I'm going to be talking about now is something more local. We asked our leaders which problems in our hospital setting they thought were the main ones facing them, and that innovation could be helpful with. And the things, we go to the next slide, please. The things that they thought were most problematic and potentially amenable to help from innovation were these. First, staffing, recruitment, human resources issues. That's become a real issue, especially with the COVID pandemic. Second big issue was the issue of space and physical infrastructure, overcrowding, clinics, the need for interpersonal distancing, major issues. And the third one was improved models of care, better access to care using different models, the kinds of things that Elizabeth was speaking to just a few minutes ago. They also felt there was a tremendous role for the better use and more extensive use of information technology, data systems, technical integration, use of artificial intelligence, and so on. And they felt finally that we could look at more creative ways to obtain funding and to make better use of the resources that we currently have. So let's go to the next slide. And this is this word map that actually Elizabeth created for me. Thank you, Elizabeth. Shows the real issues on the mind. There's an awful lot of words here for 20 odd leaders who gave us their opinions. But you can see that there's a central theme of lack of resources, lack of space, the need for more staffing, the need for improved health infrastructure, better access to care for patients, and the need for innovation to basically allow us to be much more resourceful and creative to make the best of what the current resources are that are available. So I'm going to go to the next slide. Thank you. And this slide really shows, firstly, which are amenable to innovative solutions. And some of our leaders said, well, they're all amenable to innovative solutions. And for the staffing one, the kinds of things that they were thinking about were the use of artificial intelligence to model and predict staffing shortages, and therefore ensure that we're well replenished to ensure that we can staff at times of predictable shortage. Similarly, AI can be used to generate new shift scheduling, to match resources with predicted needs. We know that we have some seasonal surges in patients coming to the emergency room, in the requirement for admissions, even for trauma-related admissions to hospital. And so we could potentially match our resources more accurately to the need. We could also simulate and improve the training so that we can shorten training time and improve the availability of staff, rather than current training schedules that are often quite prolonged and make it not very nimble to fill in gaps when we need to hire more people because of the training that's required after initial hiring. Of course, there are some innovative HR strategies that don't require artificial intelligence or machine learning, things like creative role descriptions that we can use to address needs, instead of just going with the conventional phenotypes of the different types of provider. We could adjust those phenotypes to make them fit more specifically into the needs that we have, and maybe less generalizable. And by doing that, we could shorten the training that they have, but still meet the specific needs that we have in the organization. Go to the next slide, please. The next one is by space constraints and the use of technology for this. And one of the things we've done a lot of recently in the pandemic is the use of virtual visits, using technology to do virtual visits, as many of us do from our own offices, and therefore freeing up space for in-person visits in the clinics. Also improving efficiency for patients where it's appropriate. The use of remote patient monitoring. That means, so a patient can be at home hundreds of miles from the hospital, and we can monitor their oxygen saturation or vital signs or other aspects of their care and use that data fed back to the care provider to allow us to discharge the patient earlier, secure in the knowledge that if the patient's condition changes, we'll be notified about that, and also to provide care directly to the patient at home via this technology. Elizabeth has spoken about the potential value of electronic referrals, of electronic triage, electronic consultation, and we've other digital technologies used in that space as well to employ that can help us manage the wait list much better. And of course, there are non-technology related solutions that are innovative as well in this field, from effective deployment of staff from home to save space in the organization and the hospital, to hoteling options for providers where they come in, use a space just for the time that they're in it, leave again, and somebody else comes in and uses that same space, rather than having an office that's a space that's not fully utilized in the hospital. And we talked about also virtual care delivery spaces that are separate from the in-person clinics. And many of us do that at the present time, but it certainly can increase the opportunity for in-person use of the clinic spaces. Next slide, please. Elizabeth talked a lot about access to care and improving the quality of care. And one of the themes that came up from our leaders was the use of minimally invasive procedures and extending that work that both David and Elizabeth have talked about already, the robotic surgeries and other forms of minimally invasive procedure. The other theme that was strong here was the use of software, data analysis software, to improve access to care and the continuity of care, the central scheduling and digital queuing of patients. And Elizabeth has spoken to some of this already. The improved digital interfacing between provider systems, so there's a continuum of care between the hospital and the community, and in particular, the specialist and the primary care provider, so that the patient doesn't fall between two stools, and rather that there's that clear overlap in care for patients coming in and leaving the hospital again. David spoke to the whole drive towards value-based healthcare, and that by value-based healthcare we mean outcomes that matter to patients divided by the cost to achieve those outcomes, and improving that, both our case costing and our metrics, quality metrics, so that we can drive towards that value-based healthcare. Real opportunity for this, especially as we move towards a hospital information system where we capture that information digitally and can more easily access it. And the whole role of expanded use of medical informatics came up in this discussion. And there's an example, and I don't know if Dr. Musavi is in the audience, but I know that David Pichora is one of the collaborators on that grant, and David might like to describe this work at this point. So maybe I'll just turn this over to David.
Yeah, I'm not sure if Parvin's here, but essentially this CREATE grant is about training the future highly qualified technical personnel to work in a digital healthcare space and support the myriad of organizations, whether that's government agencies or hospitals, to transition into a more digitally based healthcare system. So this is a partnership between organizations that would train these non-clinicians but technically based people, and provide internships and locations for them to learn those skills.
Thanks, David. So if there are any questions related to what I just discussed or any clarification, I'm happy to provide that at this point.
Thanks, Dr. Fitzpatrick. So any quick clarification? Again, I see another question about real-time data being used. And what I'd like to do again is we will curate that and bring it forward in the question and answer discussion at the end. Okay. So then what I'd like to do is to introduce our last speaker before we get to the question and answer session. And so that's Paul Mccauley. He's the CEO at Shared Support Services Southeastern Ontario, which goes by the acronym 3SO. And he's executive lead for Southeast Regional Healthcare Information Systems. Paul has over 2 decades of progressively responsible leadership experience in healthcare in Southeastern Ontario. He's worked in hospital, regional, and LIN roles in a wide range of areas, including information management, strategic planning, leadership development, and supply chain. He's currently the CEO, as I mentioned, and they manage all procurement and inventory activities for 6 hospitals in Southeastern Ontario. He has bachelor's and master's degrees in applied science from the University of Waterloo, as well as a master's degree in business administration from McMaster University, and he's completed the Advanced Health Leadership Program at the Rockland School of Management at the University of Toronto. So Paul, please.
Great. Thanks, Jim. They always let me go last so that you have to stay and listen to all the things that impact on procurement. But rather than lecture, thought I'd give you some questions that we usually get. And I know there's a lot of people in the audience, both from our innovation community, the university, and some from the hospital. So hopefully it's useful to you as well. You know, we're often accused of making procurement hard, and I'm hoping I can share why it's that way and talk to you a little bit about how we can try and make it easier. So just on the next slide, I think it's important to understand how we got where we are. So to quickly go clockwise around this, starting with the pen. There's kind of 2 things that balance off how we are, where we are. The one is just this general feeling from the public that public sector procurement is not good, that we tend to purchase the gold-plated hammer, that we tend to overpay for things. And the reality is most of that's a myth. The space pen is a good example. So you've probably heard the story of the space pen, that when NASA wanted to go into space, they needed something to write in space. Zero gravity creates a problem. They spent millions of dollars to develop a pen. And then the big joke is, what did the Russians use? They used a pencil. The reality is they didn't. You know, you can't use a pencil because the graphite and the problem, it breaks. And the space pen was actually developed, and the first pens cost about $400, and then they came down to about $200. The challenge is people remember, and if you're a West Wing fan, the West Wing even joked about, procurement being so bad that we paid millions of dollars for pens. The second one is what I would refer to as the e-health muffin. If you remember the e-health debacle, if you will, that happened in Ontario about 11 years ago. A lot of the outrage was around the procurement of consultants, and consultants, charging the government for a 50-cent muffin at Tim Hortons. That may or may not have been right. It was within the rules at the time, and actually said on some of the procurement groups, it did some of the large procurements around systems, and it was actually run in a very formal process. It followed all the rules, and was fair to everybody. But what remained out of that, because of this publicity, was that the procurement ran amok. And lastly, I think probably everyone's aware of the Phoenix Pay system. And if you can read the slides, it says apparently it only pays IBM. Again, if you go back and look at the system, it wasn't a procurement issue. Procurement procured what was asked for. Some of the breakdown of what happened there was actually, it was more of a structural issue within the government, and the inability for people who were using it or at the front line to determine what they want, get those messages up to the people making decisions. So I'm a bit biased, but I think actually procurement in the public sector, and I'd say particularly in healthcare in Ontario, is actually quite good. Unfortunately, there's this feeling that it does need a lot of rules around it, because without those, we will procure the gold-plated hammer. The other piece that people aren't necessarily aware of is we're very regulated by trade agreements. So in particular, 3 of them, I think we're all familiar with NAFTA, the NAFTA, the USMCA, which is the oldest one. But 2 that have more impact us recently is the Canada-European Trade Agreement, CETA, as well as the Canadian Free Trade Agreement, which knocked down a lot of the barriers between provinces. Both of these agreements have requirements around procurement that we, if we're going to procure anything, say in Ontario, it has to be open to anyone from any of the provinces. But in addition, it has to be open to anyone from any of the European Alliance, the EU countries. So those have actually created a lot of rules around how we do procurement. So on the next slide, you know, I often get asked, why does it seem so hard to sell to healthcare, and why can't you just, you know, give me a PO? And it's because of the regulations. So again, largely because of what happened in eHealth, the government at the time brought in the broader Public Sector Accountability Act. That actually defines limits in terms of what we have to do and what type of procurement procedures we have to go through on behalf of the hospitals based on what they're procuring. The trade agreements, as I said, actually dictate a lot of the processes as well. Big piece there is that procurement needs to be open. So we can be challenged not only by anyone in Canada now, but also by the European Union. Interesting enough, the NAFTA and then the new trade agreement with North America does not have those regulations as much as CETA and the Canadian agreement that set those. And there are implications to hospitals for not following. So they are required to file reports with the ministry, with the LIN, and we do have to post some things publicly. Really what we're trying to do is maximize the value received from the use of public funds. So going back to that notion that we are accountable to the public. And the key principles are accountable, transparent, that we do get value for money, that we provide quality, service delivery, and process standardization. The challenge we have from a procurement point of view is how do we meet all those needs and support the innovation mandate? And I think you heard great presentations from Dr. Eisenhower and Dr. Fitzpatrick of where innovation is needed. And it becomes a challenge for us for balancing that out. Just on the next slide, again, we also get the question of, is procurement all about price? And the answer is no, but sometimes yes. Traditionally, we do procure against the lowest price. Honestly, it's easiest to select the lowest cost bid, provided it meets your requirements. Those requirements would have some quality built in. It's also been, unfortunately, the way that hospitals have been funded through various governments, that there's a push to get the lowest cost on procurement because hospitals are compared to each other in terms of what they pay for items. I think as Dr. Pichora talked about, we're trying to move to a value-based procurement system and look at the quadruple aim. One of the challenges is it's harder to evaluate products against that aim, and it will require potentially more time on the request for proposal, request for service process, and it can take longer to create a contract. In some places, the contract really needs to start look at sharing that risk. So if a vendor is committing, for example, that they're going to improve quality by reducing time in a hospital, they may need to have to own some of that. And there may need to be some contract requirements around that, because if there isn't, we can't guarantee that we're getting value for money. And that's where we tend to fall back to lowest cost because it's easy to look at. There is a whole new field around innovative procurement. The KO hospitals, the academic hospitals, provided a very good document on the art of the possible that's available if you're interested in it, that speaks about how we can do innovative procurement. And it really is not about defining what you want to purchase. It's about defining what the need is and let the market identify the solution. So, you know, I've seen someone give the example of, you don't really want to purchase a pen. We want to purchase something that lets us document something. In reality, if we want a pen, we just want to purchase a pen. Some of what Dr. Fitzpatrick talked about, though, fits nicely innovation because there's a need, but there's no defined solution. And so if the need is to find a way to better schedule people, that may be something that becomes an innovative procurement because the hospital doesn't want to and can't dictate what the end solution might look like. In terms of the procurement on innovation, there are various ways to do that. I'm going to talk about that in the next slide, but just to remind you of a bit of a theme, some of these are very resource intensive. And we just don't in healthcare necessarily have the resources to invest in innovative procurement all the time. So we have to pick where we're going to do it. So on the next slide, I stole some of Dr. Eisenhower's pictures and kind of tried to put it for you in what it means for procurement point of view. So if you look at something going from research into healthcare innovation, eventually into a product or a service that's used in the hospital, it really does go from my screen left to right. Being at the research end, it really isn't a procurement. There's no commitment to buy. There's no need for us to be involved as an example from a procurement agency. If you are going to request data, though, because you're doing artificial intelligence and you want to investigate something, you want to tune something, there's still a process that needs to go through because the information that you want is not likely available or shareable without some type of a privacy agreement or if you're going through research, there'll definitely be research approval. As you start to develop a product or service, that's when you start to get into pilot projects. If that does involve intellectual property creation or revenue sharing, we're likely going to need a fair bit of legal involvement, and that will take more time. If not, then you've got a product and the hospital's looking at it, we can create some pilot projects to look at it. Again, at this point, it's fairly resource intensive, particularly resource investment from the innovator or the person who wants to sell the product, because there's no agreement yet to purchase. At some point, and I would agree with Elizabeth that there's not a fine line here, at some point the hospital makes a decision to purchase, and then we do have to look at formal procurement. Before then, we can have things called competitive dialogue. We can talk about options. We can discuss things, create innovative partnerships. But really, once there's a decision to purchase something, despite the fact that you might have been in, working with the hospital on a pilot project, we still are bound by regulation and by trade agreements to go through some type of a procurement. Largely what that looks like is a provincial or regional one. So ideally, we do our best to partner with Mohawk Medbuy Corporation, which is a regional organization in Toronto, but they purchase through all of Ontario. We do local ones, so across the 6 hospitals in the Southeast. And I'll talk about limited tendering. So there are options where we don't have to go to market and we can actually sole source. Again, if you look at on the spectrum, the research becomes resource intensive and resource investment. It can be resource intensive to do kind of those competitive dialogues and the innovation. Once we get to procurement, it's a pretty standard process. And again, it's structured that way to make sure it's transparent and fair to all. So on the next slide, just some recommendations. If you do have a product or a service you want to sell, I think Dr. Eisenhower nicely talked about, the hospitals tend not to get involved in things like new drug products, not necessarily some of the new things, stents and things that might go in a patient, and even some of the equipment. If you're looking at that, there's a whole Health Canada approval that needs to be met, and it can be fairly stringent. Some things like face shields have been opened up because of the need for COVID, but largely you have to investigate that, and really the hospital can't really touch anything until it's been through the Health Canada approval. If you are planning on competing around the quadruple aim and not just on price, it really is important to upfront articulate the value. So I think Dr. Fitzpatrick provided a great list of where the hospital's had needs, and you need to identify the value to solving those and where on the quadruple aim it might actually save. Unfortunately, there are some perverse incentives in hospitals around cost savings. As much as it might seem like, reducing someone's hospital stay actually saves the hospital money. So if you could drop somebody staying in a bed for 2 days, the reality is those 2 days will be filled with somebody else. And it can be very difficult to just base that on a cost saving. So it's where you have to look at the rest of the aim and say, how are we improving quality? How you're improving care to the community, that patient community health piece, or to staff. And the other one, as much as Dr. Pichora said that the budget of KHSC is large, it really isn't compared to the size of the market in Ontario, in the nation, and then in particular globally. Right now, most of the purchases we do are on the national or global scale. So if you are looking to produce a product and have long-term stability, you need to think about how it scales beyond KHSC, what you do provincially, and what you do internationally. And KHSC is looking at partnerships, with others around how we can introduce people to that. As I said, piloting may be possible. I just want to make sure people understand there's no guarantee of purchase. So it is an investment on both sides. And the hospital may not be able to support resources. So if you're thinking of coming in and piloting, think about what resources you'd actually need from the hospital, and understanding that right now that's pulled in a number of different directions. So just moving to the next slide. So I do hear from people, they'll come with the greatest product and they're just wondering why the hospital isn't purchasing it. Through the pandemic, a number of organizations across Ontario have sprung up to meet the needs. Kind of after the supply chains got a little bit more back to normal, people were wondering why, hospitals weren't purchasing their product. The reality is the majority of what we purchase through the hospital goes through GPOs, group purchase organizations. Largely we partner, as I said, with Mohawk Medbuy. If you do have a product that's ready for market or close to market, MMC does have an innovative program, an innovation theme that we can get you connected with. Beyond that, most hospitals were tied into multi-year contracts, or purchasing off contract ability can be limited because of those large contracts. And it also can create issues managing multiple products. It doesn't mean we can't do it, but it's why there sometimes is a challenge to introduce a new product. Generally, as I said, you'll need to go through some form of competitive procurement. The issues on the next slide, there are options around the notion of procurement called limited tendering. It used to be called sole sourcing. So people will say, I have a unique product, no one else makes it. Why are you can you go through all the process? So there are ways around that, but it's very limited in what we can apply that for. If there is only one vendor, that we can do a limited tendering. However, to get to there being only one vendor, you have to do the procurement to prove there is only one vendor. If there is a solution where only one vendor can provide it, for example, when hospital goes out and buys a new CT machine, we are really locked into a partnership with that vendor for years to get parts and to get service for that product. So there's situations like that where because of intellectual property, technology fit or product fit that we have to link in. There are time issues due to unforeseen circumstances. So the pandemic's a great example where, it wasn't seen. We've had to use limited tendering, but generally those options are pretty limited. So it's not about unplanned circumstances, it's unforeseen ones. And there are some around intellectual property provisions where the intellectual property is owned and cannot be transferred. The limitations do not include location. So until CETA, we could actually specify a need for there to be previous experience in Ontario or in local regions. We can't do that as much anymore. So just being a local vendor does not automatically become a reason for limited tendering, and we need to look at other options. As I said, timing issues due to lack of planning and a previous relationship due to research or a pilot. Again, if it doesn't fall under one of the limited tendering issues, that's not a reason why we can just issue a contract to one individual or one firm. So on the next slide, talk a bit about the kind of IT technology A's, and there's a few questions on this, I think, as Jim said, that we could get to later. The IT systems and procurement follow the same rules as all other items. The province is trying to create standard vendor of records to make it easier to purchase these systems so that we don't have to keep going out every time, trying to do that across sectors, not just healthcare. The challenge, I think, going forward, so everyone's aware, the 6 hospitals have signed up to implement a product called Cerner. So it is a health records information system that all the hospitals in the Southeast will use. It'll be interconnected so the information flows smoothly between the hospitals. It also includes the concept and the actual pieces of technology that will allow us to integrate to primary care and to others in the region. So eventually, potentially long-term care homes and others that are interested. So that's all there. That doesn't mean, though, that there won't be need for other types of systems. For KHSCs in particular, they also use SAP for business and health human resources functions. So largely KHSC will be around SAP and Cerner, but there will be other pieces of technology that will fit in. The message is, they will need to fit into those 2 systems. So if you're interested in selling it, it'd be about understanding what addition your product adds. So again, Dr. Fitzpatrick talked about scheduling people. That's not necessarily a forte of these systems. So that might be an add-on that would integrate in. And in addition, privacy and security risks, I think Dr. Pichora mentioned, is becoming a huge issue. And the technology, will have to meet those, and any concerns around that would have to be addressed. In terms of the Cerner implementation, just get forming now, getting kicked off, and really it's over the next 24 months to 36 months is the go live time where the 6 hospitals will be going live. So next slide, just kind of my wrap up and suggestions, and I think my name's at the end of the slide deck, so always happy to talk to people. We are in a really high regulated environment around procurement. It can be seen as a deterrent to innovation. It doesn't mean we don't want to do innovation. We have processes that will follow, and we can definitely be involved in it. If we focus on the value, and you focus on the value you can bring, it makes it easier to determine how we'll do the actual procurement, whatever that looks like, and to make sure that we pick the right solution. It is important to understand the resources. Again, don't mean to keep harping on it, but the innovative procurement is a resource investment for both sides. We want to make sure that when we get into it, it's to solve the right problem. And the hospital will be limited in terms of how many we can take on. Again, think provincially, nationally, internationally. There are other organizations that can help support. As I said, if you have a product from an innovative point of view, Mohawk MedBuy does have a whole process to go through that helps. And lastly, as I said, feel free to call. Happy to try and help out. We don't make the rules, but we are accountable to make sure, supporting the hospitals to make sure that they're followed and that no one, ends up on the front page of the paper or gets called by the Auditor General, which is our worst fear. So hopefully that was helpful to set the stage. Again, I don't want anyone to think we can't do innovation. Absolutely can. It's just a different process and can take a bit longer than you may want it to. So I think I'll end there, Jim, and happy to answer any questions as we go through the Q&A.
Thanks, Paul. Actually, I think that could be a good segue into one of the questions that came up in the Q&A. And while I ask this question, please take a look also at the questions that we have on the slide here that we put together to seed some further discussion. One of the questions that came up during the progression of talks was, is patient vital or non-vital data being tracked in real time by hospital units now? And if so, who is the end user consuming the data? How are the data presented? And how is that information currently relayed to key stakeholders? And this is particularly linked to the talk that Dr. Fitzpatrick gave. So, Mike, I'm not sure if you'd like to take that on first. But
sure, Jim. I think obviously we have continuous recording of vital signs of lots of data. But I think if you're talking about the use of artificial intelligence and machine learning, no, not in general. We have some, David Maslow, one of our intensivists, has a special interest in this, and he is using that data. I know that Mohammed Mandani, who from St. Mike's Hospital in Toronto, has done that, and came and gave us a lecture on this recently. The talk about the use of and then using the AI to determine which of those vital signs gave the best index of prognosis for the patient, and therefore helped align basically resources, intensity of monitoring of the patient with the data. We don't have that capability for use at Kingston Health Sciences Centre at this point.
Okay, thanks, Dr. Fitzpatrick. The next question that I was going to ask was that, sorry, one sec here. Let's pull my list back up here again. It was a question about timelines. So what do the timelines for software implementation look like for past tech initiatives? Who'd like to take that one?
Well, I guess I could start, Jim. And unfortunately, there really isn't an answer because it depends on the initiative. I mean, I'll build a little bit on what Dr. Eisenhower talked about, and she could jump in around the wait times, because some of that was a tech initiative. And to be honest, it's probably taken 8 or 9 years, but it developed as literally an idea and then went out from there. If now that we have a system in place, the actual tech implementation is relatively easier. What Dr. Eisenhower is working on is more the change management of getting people to use it and that integration. So that's where it really depends on where it's hitting. Is it purely just a software and integration? Is it interfacing, or does it involve actual change management, which is more where the time can come in?
Yeah, I will just add to that. It like with many questions that people will ask, it all depends. So the example of converting faxes to electronic referrals and implementing a waitlist management system, the pilot from start to finish is going to be done in 9 months. Then there's the scale and spread through the rest of the organization and the region. And you forget sometimes when you implement something new, part of the timeline to get there is the willingness of the people in the groups with whom you are working to implement it. So clearly working with early adopters in the first bit of that is important, not just because they're going to work their way through the kinks and the problems, because that particular initiative has 3 different sets of technology and vendors connecting to each other and changing the workflow in the intake in the office. But it also means that we can generate some of the evidence that it's a good thing to do because it saves people time. It is good for patients. It's good for the secretaries. It's good for the family doctors, and so on and so forth. So that timeline is pretty aggressive, but it's about 6 to 9 months. But the point that Paul was saying is that sometimes when you look at the list of problems that Mike dealt with and the potential solutions, some of those potential solutions don't need an outside vendor. It needs some work and attention done internally to develop our own solution. And that's what a lot of people did. And sometimes those solutions spin out to companies. And that's what happened with Novari. Novari, which is now an international company based in Kingston, grew out of work to improve surgical scheduling. And that is just one of multiple different platforms or tools that they now offer. And so it's sort of interesting to go full circle and be in a vendee relationship with Novari as we work on some of the other solutions to waitlist management internally.
Thanks, Dr. Eisenhower. I'm going to do one more question from the chat, and then after that, Dan Desjardins, and then Sharam Yousefi, just to I see their hands are up there. The next question then is, would it be possible for an innovator to approach 3SO, so your organization, to elucidate a pathway to working with healthcare institutions that you serve? Paul, would you like to take that one?
Yeah, I think my email is likely going to pop up at the end. Happy to talk to people. I guess the only word I'd be cautious of is a pathway. It might be a very winding one. It's not. There's not a clearly defined path, I would say, for healthcare in Ontario right now for pretty much anything. But I can help provide any advice or point people in a direction if they'd like.
Thanks, Paul. That's like the Beatles song, right? The Long and Winding Road. Yeah. So, okay, Dan, please.
Thank you very much, James. Dan Desjardins from King's Distributed Systems, right here in Kingston's backyard. At least 3 of the strategic directions or pillars of innovation involve data science, predictive analytics of some sorts. What thought has been put into where that compute power is going to come from? Big hospitals have big HPC centers, but 95% of hospitals don't. And the key to a lot of the AI power, a lot of doubling of AI or compute power consumed for AI every 3.5 months, it's going to bottleneck pretty quickly. Where's the compute power coming from that's going to support all this innovation?
Yeah, it's Dave Pichora here. I can partially answer that one for you. I mean, our main data center at KHSC is in KGH. Part of our new tower is a new data center. But increasingly, our large platforms are going out to the cloud. The Cerner is a partnership with Amazon Web Services, and that entire enterprise will be hosted remotely in Canada by Cerner. So it's a mix of, and there's other things that we're doing provincially that, for example, are hosted by Queen's Computing.
So Dan, it's Elizabeth. I was just going to add a bit to that. Part of the problem is not just the computing power, but getting the right data curated, accurate, to play with, and to play with in a way, shape, and form that takes into account patient privacy. So there's been a lot of discussions ongoing about that because our current health information system does not automatically collect a lot of the things that people might want to know to start to do modeling around predicting where patients are going. And furthermore, a lot of the interest in some of the machine learning or AI applications are not actually in the patient care space directly. They're indirectly in administrative planning and scheduling and other things, which is separately stored from a healthcare information system, shall we say. So we have put together a group that is discussing how we move forward to be a more data-informed organization. And we recognize that will require more person power in the decision analytics space. We are partnering with the Centre for Health Information, led by Amber Simpson, which has data scientists and is also looking to improve access to cloud-based computing in a kind of a shared way, and developing a sort of a strategic plan when Cerner goes live for data governance and many, many other layers of things that have to happen. But some of the roadblocks to doing very much yet are accessing data that is what it's supposed to be when those systems are not necessarily collecting all the information that's needed, nor are there people that have the time to curate and clean data before you even begin to work with any kind of analytics approach. And I'd welcome some of Amber's, I see she's here, some of Amber's comments on this too.
Yeah, I made the comment in the chat. I think there's a lot that we can do, certainly on the operations side and the value-based care side that David talked about, without any kind of real CPU or GPU power. I think when you get into the deep data sets, obviously the compute power becomes a thing, but I think there's a lot of really simple analysis that we could do. You know, we can look at the wait times initiative that Elizabeth is working on. You know, that's not fancy. That's just data analysis, really. It's hardly even AI.
Thank you.
Thanks, Amber. Sharam, please.
Thank you so much, Jim, for possibly putting this together, moderating. This is long overdue for given how much innovation happens in the city of Kingston around healthcare. And thanks, David, Elizabeth, Michael, and Paul for adding information here. So yeah, I'm Sharam Yousefi. I'm a professor of engineering at Queen's for 20 years now and associate dean in engineering, co-founder, CEO of Mesh AI, a novel staff scheduler for healthcare. Since 2018, we've been serving medical systems, hospitals in Canada, US, and Australia. One of the things that I've noticed as a distinguishing factor for success when innovation is brought into healthcare is the level of support that is provided, capacity that is provided to currently very overstrained healthcare systems to take on new projects and experiment with pilots and things of that nature. I'm wondering what thoughts are going into really providing some capacity for innovation so that we get out of this catch-22. We don't have a staff, but we don't have time to look into, optimization of a staff, which is the sort of thing that I hear every day. Thank you.
I'm not sure who'd like to take that question.
Yeah,
Well,
when it comes, I can say.
Yeah. Go ahead, Mike.
Well, I was going to say, David, I mean, I think it's a great question, Sharam, a great question. And it's true, there's no good time. I'd say that right now is probably, in particular, not a good time, not just because of the pandemic, but specifically because we have a lot of our staff and our physicians engaged in the introduction of the new health information system, which will ultimately, I think, provide a lot of useful data for us and improve, really help us on our road to value-based healthcare. But because of it, we're really stretched, and we're going to be really, very stretched in the next, 3 years probably, as we bring that in. It's going to be difficult, and so that's not an excuse, Sean. I think what you say is absolutely true. This is very important. Somehow we have to make room for innovation, and I think that that looking back and forward, I think this particular crunch time over the next couple of years is going to be difficult. But hopefully, even within that, we can make find some flex for innovation, because it's really very important. If we're not moving forward, we're moving backwards.
Yeah, so this is really an issue for governments and public policy, because the healthcare system has intentionally been run very close to the line for years and years, and the pandemic has stressed it and demonstrated the fragility of it. Everybody would agree with the notion that a well-funded hospital will plan for 18% or 15% empty beds to allow for stretch capacity. And if you take that analogy farther out, where's the budget line for R&D and innovation and all of those things? And it's just has not been there. And I think governments are going to have to decide whether that's something that they want to commit to.
So one of the things I did in my interviews, I mentioned International, I went and met with the head of transformation for the NHS and the lead of one of the innovation hubs in London. This was all pre-pandemic, of course. And there, the NHS, bless their hearts, had decided that one of the challenges they saw was a lot of research happening with a lot of evidence suggesting things should be implemented and translated into practice more widely, but it stalled because there wasn't anybody there to do exactly what you're describing, manage the projects, do the change management, get people engaged and excited, get champions involved, and so on and so forth. And they put huge amounts of money in the NHS and the hub and spoke model across the country to identify the innovations worthy of translation that there was a champion for, and to move them out. And they were doing fabulous work. And then they also leveraged the investment from the NHS to say, we are here and ready to test and evaluate your COPD app or your whatever. And so they made themselves kind of the competitive hub for generating the evidence that others might use to help promote or not their product, and to help the NHS make decisions about which products it might want in future. But the one hub, there were 14 hubs, I think their budget was £10 million a year. And that was based out of King's College. And you multiply that by 14. That kind of investment in innovation and a deliverable around innovation and translation and implementation into practice has we've missed the memo in Canada about that. And we have innovation at a sort of a research level, but not at a translation level in any systematic big way. So what I've been trying to do is cobble together bits and bobs of funding to help get the projects that we're working on going, and hoping that when you have a critical mass and then you generate new projects and then you get more money, you will have something that's sustained. But boy, it's not easy.
Thank you.
Thank you. The next question I'm going to go to is there an appetite for focusing on personalized medicine, and particularly business focusing on personalized medicine? And what opportunities or roles would you see there?
Well, I think I'll lead off. I'm sure Elizabeth has lots of ideas, and Paul will introduce the reality. Notionally, we'd say, well, of course, why wouldn't we do that? And and we're getting our feet in the water with this. KHSC was selected because of our early pandemic performance with lab testing, with standing up a huge capacity for PCR. We were selected to be one of the 4 hospitals or sites in the province that does whole genomic testing. And, so we're now tailoring the evaluation of the genotype and phenotype of COVID in our communities and our approach to that. So early days, but again, it gets to this value-based equation. Notionally, personalized care may be more expensive care, or it may not be, but it's one of the things you have to consider.
Thanks, Dr. Pichora. Anybody else have some thoughts they wanted to share on that personalized healthcare?
Sure, Jim. I think that really is a very exciting path for the future at KHSC and elsewhere. We do a lot of genetic markers for different types of cancers, and those are extending all the time, being more and more specific about that. What we haven't done a lot of here is whole genomic mapping and linkages to disease, exploration of that association between certain genetic linkages and disease. There's no question, larger hospitals in the States like Geisinger have done this very successfully. And I think it's certainly a very exciting opportunity for the future.
So I'll just add to a little bit to that, because being in cancer research for many years, of course, this was the buzzword for at least the last decade. I think the expectation, at least in the area of therapeutics, that measuring all sorts of different things about people and their cancers are going to lead to transformative changes in cancer outcomes have been disappointing. I think put that right up there. That doesn't mean that tailoring treatment appropriately, and most importantly, not offering useless treatment, and that applies across the spectrum, won't be the smart way that we can be thinking about going forward. Most discussions around personalized medicine involve considering huge analyses of genomic and epigenomic data sets that are really kind of data repositories, but without a question associated with them or a direction. And they're not really about making decisions to tailor therapy or diagnostics today. All that being said, some of it funnels through that very narrow evidence-based window into practice and care. And there are many, many projects here at the research side in that space. So I'm not sure if that's helpful. I would hate to say that our innovation portfolio was solely resting on this notion that personalized medicine is going to be a transformative across the board, because I think there are just too much evidence to suggest that hasn't been, that we were a bit Pollyanna-ish when we started to think about that 10, 15 years ago in the cancer space. It's not gone away, but I think we have come to understand that there will not be wide-scale transformations in care based on genomic understandings of cancer in patients as yet.
Thank you. Actually, I think that's a good way to segue. And what I'm going to do now is bring a couple of questions. One was raised by Amber Simpson, but also another in the slide that we had as sort of thought starters as well. And that is, if we take a look at the regional ecosystem, and I think that was very much, the hope. And by the way, I would very much like to acknowledge the work of Dr. Eisenhower and her colleagues at KHSC in getting this innovation workshop. So Sharam, to your point, I think really the credit is with them. And so I think just the last couple of minutes that we have is to both recognize but talk very briefly about the ecosystem that we do have. Because as Amber Simpson was pointing out, there's a lot of capacity, capability, ideas, both associated with Queen's. There's work and groups at St. Lawrence College as well. There'll be people and companies out in the community. And I think that, certainly my few cents would be that part of the Health Innovation YGK initiative, which the city is leading, and which was funded with the FedDev grant, is to try to help both bolster those various partners in the ecosystem, as well as to really try to start building out more interconnection. And so one of the things I'd like to do is just very briefly acknowledge, the Health Innovation YGK group, and actually if somebody from there could also put the link to the website for the website related to Health Innovation YGK, which I think Kingston Economic Development actually hosts. That's one, but you can see the various partners that we have here. My sense, from the discussion is that, to the extent that you can get better understandings of the problems that KHSC and other hospitals are facing, and I'm going to say to the extent also that anything you can do to better understand what they look like. And so partially, for example, to the, the data preparation and things like that, like, how does it even come to your door? I think will help people better, you try to go as far as you can in identifying opportunities and then trying to develop out solutions, from what you can find available. And those can be from network conversations. There will be workshops going forward from various of the partners in the HI YGK as well. So please look for them. There's various programs such as the Build to Scale Health program out of the Dunin-Deshpande Queen's Innovation Centre. Queen's Partnerships in Innovation also has a number of different programs as well. And St. Lawrence College, as I mentioned before, but also supports and mentors. And so there's a mentor network. But I think that the comments I would make is really trying to build out and draw on that network more than perhaps we have already, so that we can get closer to the mark before you start knocking on doors to see about piloting and things like that. To start with, could be a very helpful strategy. Okay. Now, does anybody have anything else that they would like to add to the comments that I made? There, Elizabeth?
I don't really have any comments to add. I think what I want to, you have all heard today, what are the sort of top of mind pressing problems from clinical and non-clinical leaders in the hospital. And some of you on this call may have ideas about how we might solve some of them, whether at Queen's or in other small businesses in our area or large businesses in our area. It's really, how do we kind of capture the ideas to move to a solution when really the support of evaluating potential solutions to problems really will need to come from the person who brings forth the solution at this point. I wish we could say we had 10 million set aside for evaluating new ways to manage the development of different models of care or access to care or wait times, but we don't. So I think the ideas that might help with solutions are great, but there are also ideas out there that, you know, from talking to clinicians is a big problem that merits a solution. And so I don't want to close the door on those just because you haven't heard about them today. And maybe some of the initial work, as Paul said in his talk, isn't really about procuring a product. It's about evaluating the merits of that product in the context of a Canadian hospital with people who might be excited about the solution you offer.
Thank you. Dr. Pichora, Dr. Fitzpatrick, any additional comments you'd like to add?
Well, thanks for participating, everybody. It's been a really great session, and I think, you know, we do need to think local and take advantage of the innovative and research ecosystem that we have here in Kingston and the region, because there's lots of great opportunities, and they don't all have to be really expensive.
Yeah, and I would say David, I think that you know, when I was thinking about the things that we look for answers for, you know, it reminds me of, you know, when Henry Ford was asked, did he ask others for their opinion before building the first motor car? And he said no, because they would have, if I asked them what they'd want, they would have told me a faster horse. And so I think that from within healthcare, we're like that. We have a certain blinkered vision. There may be much better ideas that you have that we haven't even thought of. And so we have to be modest about our perspective on this, and look for the exciting ideas that you might have. Really enjoyed the session and the interest and some of the great questions and comments as well that came through. Thank you.
Thank you very much. Any last comments from anybody else before I head to the closing comments? Paul, did you have anything else that you'd like to add?
No, I echo what everyone said. You know, I will say I have a strong tie to the hospital. I have a strong tie to Queen's economically. So happy to help out however I can. I do think Kingston can succeed. We just have to figure out which pieces to take on. And hopefully people are hearing somewhat of a plea for the hospital to find a way to help, you know, do these innovations without involving staff or with supplementing with staff. So anything we can do to work on that would help the hospital, the university, and most importantly, the people in our community. So thanks for letting me be involved, and feel free to reach out.
Thanks, Paul. Actually, if I could just slip one last question, how will original independent ideas be channeled or proposed, and to whom to make them happen? Did you want to just offer very quick thoughts on that? I'll add two more thoughts myself, Paul, if you want.
Well, I think Carrie shared my email address. I'm happy to help out in taking them. I think as Elizabeth outlined, there are priorities and themes at the hospital, so they can't really take on everything. I can help direct people other ways, and as things come forward, can work with Dr. Eisenhower at the hospital. I don't want anyone to think that we're going to be able to act on a lot of these, but happy to at least listen and provide whatever advice we can.
So I think that was Dr. Moran who was making that comment or question. Maybe I'm wrong.
Yes,
so I think it's important to remember that the hospital already has a structure for decisions about innovation, and that lies within our program structure. So if you say want to, as I did when I was head of the cancer program, You hear that we need to be moving towards adopting prostate brachytherapy here. Well, there's going to be a process that starts with the program council discussing it, looking at working with you to develop a business case, finding the support and moving it forward. And it only really goes up to the top layer of the hospital if it requires extraordinary investment. But programs, so if you're in the Department of Medicine and you have an idea that needs endorsement by your division to go to the Department of Medicine program for new ways of doing things, we don't need to go to the top of the rung all the time. We need to use our program structure and program council structure to move things ahead and to help great ideas get realized.
Thank you, Dr. Eisenhower. Good. Okay, so I think we've had lots of great discussion. I very much hope that this is really the start. And hopefully the excellent talks from our speakers have given you more of an idea of the problems that the hospital is thinking of and the priorities, as well as an idea of how you can start to get ideas in. Thank you, Paul, very much for offering your email and contact information. But I will also remind everybody, lots of discussion and networking and bouncing ideas around to help further develop them within the broader ecosystem. And so we touched on a number of those partners. I would, before we wrap up, like to thank Teresa Macbeth and Carrie Holden from KHSC and Dan Henry from St. Lawrence, and my colleagues Bruno Moraes and Megan Soroka from DDQIC for their help in putting this together. I've certainly very much enjoyed it, and I very much enjoyed the talk. So once again, a big thank you as well to our 4 speakers. Okay, and so please, keep your eyes open for workshops and various kinds of activities. And don't forget that Health Innovation YGK link that Ben and Malcolm put in the link. And of course, please don't forget Paul Mccauley's link for KHSC. So thank you, everybody. Very much appreciate you joining us and for the very thought-provoking questions. Thank you.